Welcome. This audio PowerPoint presentation is to prepare you for diabetes mellitus classroom activity. This is just the Cliff Note version to prepare you for the flipped classroom where you will be doing and implementing all of these concepts or things about diabetes in this presentation. This is not the one that we'll be testing from, though the content is just a condensed version of the bigger one. Okay, points to be addressed. Normal and abnormal pathophysiology. We'll talk about hyperglycemia, the types of diabetes mellitus, the manifestations or signs and symptoms of diabetes, what is involved in diagnosing somebody with diabetes, the plan of care or collaborative care that we are going to see, and some of the complications of diabetes. Normal pathophysiology. There is a video here that I would like you to watch. It's a little over 4 minutes. However, you can stop at the 3 minute and 5 second where I think the slide that comes up says diabetes and injected insulin. This just gives you a good visualization of how insulin and glucose work and what is normal. There are multiple organs in the body. Obviously, the entire body relies on glucose and insulin. But there are key players to this. The first one is the pancreas. Pancreas has two functions in the body, an exocrine function, which assists with digestion, and the endocrine function, which is your islets of Langerhans. The alpha cells, beta cells are the biggest ones that we're going to talk about. So really we're focusing on the endocrine portion of the pancreas. Alpha cells secrete glucagon, which is then converted into glucose, so then we have, glucose available. Beta cells secrete insulin to decrease blood glucose levels. It works basically as a negative feedback system. I always have a basal of glucose because there's certain cells in my body, such as the brain, that rely on a constant circulation of glucose. Well, in order for glucose to be able to get into the cell, we need insulin, just like the video showed you. Insulin, see it as the key. It opens the door for glucose to come in. If I do not have insulin, then the glucose does not go in. Okay? So I need that happy medium. Well, where do I get glucose from? We get it from the GI tract. Obviously, when I eat, I get a bolus of, carbohydrates, proteins, fats, different things that are absorbed over time and are converted into glucose. The liver also plays a central role by balancing the uptake and storage of glucose, and it releases glucose back into the vascular system via glycogenolysis and glycogenesis. But then you also have cells. Your muscle cells and your adipose tissues have special receptors that the insulin attaches itself to, opens the door, so it's like a key, lock and key effect there. So all these play effect to keep my blood sugar, my normal blood sugar, between 70 and 105. Or your A1C, which is your hemoglobin, HbA1c, but we call it A1C for short, is your glycosylated hemoglobin, less than 5.7%. We'll talk a little bit more about glycosylated hemoglobin later. I did give you a little picture, a little kind of reminder of how insulin and glucose work and work on that feedback system, how the liver is involved, and the pancreas and the GI system. There are a few other videos here if you like to watch videos and get a better idea and have some visualization. These are all really good videos that I have watched, all of them. You could do that on your time then also. All right, let's talk about the pathophysiology. So take that normal pathophysiology and we're going to make it abnormal for diabetes. But diabetes, and some of those little videos before showed you some abnormal. Diabetes is a chronic systemic disease characterized by either a deficiency, characterized by hyperglycemia that is caused by a deficiency of insulin action or a combination of both. So we need insulin. Remember, it's the key. So with diabetes, we may have no insulin or we may not have enough insulin. It really depends upon the type. So it doesn't matter if I have a lack of or none, what happens now is that the glucose cannot get into the cell, and we need glucose for energy. So if the glucose is not in the cell has no energy, it has no way to function, and all that glucose is in the blood or the vascular system, which makes us hyperglycemic. Peripheral resistance is where the cells no longer are receptive to the insulin. So you can also may see this called insulin resistance. The cells may not respond to insulin the way they should. The pancreas will then continue to try to make more insulin to kind of overcome the resistance, so I can still get insulin in there. But over time, if the pancreas is working overtime, you know, it's just like humans. If we work overtime, we get tired and we quit. So that's what the pancreas will do eventually. So we try to, even if they have peripheral resistance and still have some insulin out there, we still try to help these people out, okay? Statistics is your next slide, and go ahead and follow this. Look at a few things. Biggest things I want you to see is that diabetes is an epidemic in America, especially type 2. We are seeing a dramatic increase in type 2 diabetes in children due to obesity and sedentary lifestyle. You also see some statistics about, you know, ethnic groups and things like that, but when we talk about type 2, we'll address that. All right, hyperglycemia. We already know that it's blood sugar greater than 105, so high blood sugar. But does everyone who has hyperglycemia have diabetes? No. There are many things out there that can cause somebody to be hyperglycemic. Does that mean their blood sugars are going to be like 400 and 500? No, they might be, you know, 150, 180, that type of thing. But it's still hyperglycemia. There are medications out there. I mean, there's an extensive list. I'll give you a few here. Corticosteroids, such as prednisone, can cause somebody's blood sugar to go up. So a lot of times the patients in the hospital on corticosteroids, we might be checking their blood sugar. We might not be giving them any medication, but we're just checking. Lithium, which is an antipsychotic medication that is discussed in Nursing 114, can cause somebody to have high blood sugar. Epinephrine, thiazide diuretics, all of these ones can cause, so there's medications that can cause me to be hyperglycemic. Some of these are long-term medications, some are just short-term. There are treatments out there, such as maybe in 111 you guys learned about tube feeding. In 112 in caring interventions you learned about TPN. A lot of times in the hospital people are on these types of treatments. We're going to check their blood sugars because they might be elevated and we may have to treat. Stress. Stress increases, we have higher levels of epinephrine in our system, and we also have a higher level of circulating cortisol, which then can cause us to have hyperglycemia. So it doesn't need to be stress like anxiety stress that we think of it, but it can be the body going under a stressor like an illness or surgery or trauma or something like that. So a lot of times patients in the hospital, blood sugar might be a little bit more elevated than normal. There are other illnesses out there, such as an infection. Cushing's syndrome, which is an adrenal issue that we have more circulating cortisol. So a lot of times corticosteroids, especially long-term chronic use of corticosteroids and Cushing's syndrome look very similar because one is Cushing's syndrome from inside the body, or disease is there's an issue with an organ that caused me to have high levels of cortisol. And corticosteroids means I'm taking something from without, causing me to have higher levels. Either way, they both can have problems with hyperglycemia. Any other pancreatic issues, pancreatic cancer, pancreatitis, those types of things can cause me to have hyperglycemia. So you also have to think about a diabetic who comes in who already has hyperglycemia and maybe is on some of these medications, or they're going to have surgery, or you know, they have an infection. Their blood sugars are going to be even higher than normal. So a type 2 may get upset. It's like, oh, at home I only take, you know, oral medications. Why are you giving me insulin? Well, this is why. Because, you know, their body is going under a stressor and they may need more medication than their oral to help them out. All right, let's talk about the different types of diabetes. There is a category of prediabetes. This means your blood sugar is above normal, but is not diabetic, because patients who are diabetics are above 126. That's when we diagnose them. So somebody who's in the range of 105 to 126 is considered pre-diabetic. Or their A1C is somewhere between 5.7 and 6.4%. What prediabetes is what we use in healthcare as a warning. Hey, listen, research has shown that you have prediabetes, that you are at risk for developing type 2 diabetes within the next 10 years. So let's do some lifestyle changes. Losing weight is the biggest thing, either through a healthy diet and exercise. This can reduce the risk of diabetes by more than half. And we also know that it's also good for other things within the body. They may have to be put on some kind of medication. Glucophage is a big one that we see in the prediabetes, and we'll talk about glucophage a little bit more later. Type 1 diabetes used to be called juvenile diabetes. Common onset is less than 30. It only accounts for 10% of all diabetics. So type 2 is, again, like we said in the statistics, is an epidemic. It's more common in men, especially young boys around the age, anywhere between ages 10 and 13. It is characterized by an autoimmune destruction of the B cells. Remember, the B cells produce insulin, so if they're destroyed, they're not making any insulin at all. So it results in a high blood glucose level. A lot of times, this autoimmune destruction can be caused by a viral. And there are some genetic links. Why do I get a virus and my brother get a virus? I don't get diabetes, but he does. So there are some genetic things that they're looking at. But it is an autoimmune destruction. They have high blood sugar, and because they have no insulin at all, that means the cells are not getting any glucose at all. So the cells are starving. So when you're starving, you start breaking down your body fats, just like losing weight. However, they're not trying to lose weight. Okay? When you start breaking down body fats, you have ketosis. It means I have ketoacidosis. I am doing these ketones in the blood. That is not good. That causes DKA. Okay? So we got to remember that, because we are going to talk a little bit about DKA, and now you already know a little bit about it. But the type 1, the thing about them is that they do have to take insulin every day. Multiple injections, or they could be on an insulin pump. Type 2 diabetes. Usual onset is age 30 or over, and obviously the older we get, the more our risk gets. This used to be called adult onset, but now remember, increasing type 2 diabetes in children on that statistic page. So that's what that increasing is. It is characterized by a lack of insulin from within the body, so the beta cells aren't producing enough. They're still producing some. Or they can have peripheral resistance. Remember that insulin resistance. They have the insulin out there, they just can't get it into the cell. Or it could be a combo of both. Our risk factors. The older we get, the higher our risk. So usually the happy age is usually higher than 55. It increases your risks. Being obese, having it hereditary, it has been known to be passed down from family members to family members, and it could be an actual gene, or it could be lifestyle. Lifestyle can be a hereditary thing because we learn things from our parents. It's a learned behavior. In that statistics, you would have seen that there are higher risk groups, ethnic groups out there that are higher risk, and obviously if we add a 55-year-old obese African-American woman, she has a higher risk than a 35-year-old Caucasian woman who's not overweight. Okay, but you can see these groups here. I also want you to add Asian or the islanders. They are at a higher risk too. The thing about type 2 diabetes is that it can be controlled with diet and exercise alone. They may have to add medications, okay, but one key thing is that type 2 can control it with diet and exercise, type 1 cannot. Manifestations. These are just some general. Type 1 is going to be acute or a rapid onset of these. Type 2 is not as dramatic. They're not going to have as much urinary output or much thirst or hunger, and they definitely won't have weight loss. That is specific to type 1. Okay, so let's talk about these. Polyuria is obviously increased or frequent urination. Okay, this is due to the osmotic effect of glucose. When you have large amounts of glucose in the kidneys, it exceeds the amount that can be reabsorbed. So the glucose is sitting or is retained in those renal tubules. And what happens is that when that happens, glucose attracts water. So I get all this water and now I have all this urine outflow. Okay, so it has to do with that osmotic effect of glucose. So I'm peeing, tons of urine. Well, what does that do to my volume? It depletes it, so I become dehydrated. When you become dehydrated, your thirst center is triggered. Thirst center says to you, drink, because you're dehydrated. Well, I'm peeing at the same time, so it's a domino effect. Okay, so they're peeing a lot, they're waking up 2-3 times during the night, they get up, drink tons of water, and peeing. Okay, but then they may have this polyphagia, and again, this is a little bit, these 3 P's are much more pronounced in a type 1. Type 2, I'm older, it can be rubbed off, oh, well, you're a 70-year-old woman, you're not going to have a good bladder or whatever, okay? But polyphagia and the weight loss is highly type 1, okay? So polyphagia, what is happening? Why am I eating all the time? Why am I so hungry? Well, remember, type 1 has no insulin. So if I don't have any insulin, then the glucose cannot get into the cell. And if it can't get into the cell, then the cell starts starving. When the cell starts starving, it says, you need to eat more. So I'm eating. I'm eating. I'm eating tons of food because I'm hungry all the time, but I'm losing weight. Why are you losing weight? Well, remember, the cell is starving. I have no insulin to get the glucose into the cell, so I'm eating, so all the glucose is sitting in the vascular system. So my cell keeps starving, and I start on my fat stores first. Okay, just like if I'm losing weight, I start on my fat stores first. Well, then what happens when the fat is gone? I start getting into the muscle. But remember, when we start breaking down fat, we start at such a rapid rate, we start having ketones, and we start having ketoacidosis and diabetic ketoacidosis. So that's why a type 1 is acute rapid. They can only have this problem for a short period of time before they are significantly ill and may be hospitalized. A type 2 can have type 2 diabetes for years before they realize that they have a problem. And type 2 diabetics are usually overweight. Both of them will have malaise and fatigue. You have this hypermetabolic state going on. Everything's all awry inside. So they're going to be tired, can't feel like they can't do anything. Blurred vision, infections, and the paresthesia is very unique to type 2. Type 1s can get it, but this is usually type 2s. Blurred vision happens because I have high blood sugar, I have all this glucose, it attaches itself to nerves, it distorts the retinal nerve, causing me to have blurred vision. So what happens is they go see the eye doctor multiple times. I just got new glasses, and now they're not working. Well, then usually the eye doctor says, maybe you need to go see your healthcare provider and get some blood sugars checked. That can be reversed. Okay, but once you get to blindness, obviously that cannot be reversed. Infections, they have repeated yeast infections or other types of infections in, the vagina or any of the folds. They may have, infection of the toes or feet or something like that because the disease has been a little rampant for a long time, causing them to have paresthesia or vascular issues to the feet. So these are some general manifestations they may see. All right, some diagnostics. How are we going to diagnose this person? Well, obviously, we want to do fasting blood glucose. Fasting means before you eat or drink anything that has carbohydrates or sugars or anything like that. They can usually drink water before fasting, but nothing else, okay? So it's at the beginning of the day. The blood sugars are greater than 126 for diabetes. They may repeat this again. They may have you come back in 2 to 3 weeks and repeat it again, just in case that was a fluke, okay? But if you are having symptoms and your blood sugar is 200, it might not be such a fluke, okay? They can also do what they call a postprandial or a casual blood glucose, means it's irregardless of meals. I could have eaten breakfast or something. I believe the number for that one is above 200, because normally if I eat and you check my blood sugar, it may be on the high end of normal, but remember, I have a normal working pancreas, so the cells are working correctly. once they have, some of these, or, even at the first office check, when they're checking the fasting blood glucose, they may go ahead and draw a glycosylated hemoglobin. A glycosylated hemoglobin is an average of what the patient's blood sugar could have been for the last 2 to 3 months. 2 to 3 months is the life of a hemoglobin. Okay, so we're measuring the percentage of sugar that has attached itself to the hemoglobin. It is not a hemoglobin. We are not checking a patient's hemoglobin level. We're just checking the sugar. Okay, so we check that. But, that's going to tell us that they're average. It's not going to tell us if they've had a really high, low, or a really high. A glycosylated hemoglobin, obviously normal would be 5% or less, so I'm hoping I'd be 5% or less. Pre-diabetes, we already talked about that, but for somebody who's a diabetic, it would be 6.5 or higher, would indicate that they have diabetes. Then, now write the goal down, because once we have diagnosed with diabetes, they're going to continue checking their glycosylated hemoglobin on, routine visits, and they want diabetics' glycosylated hemoglobin, or A1C, to be less than 7%. An oral glucose tolerance test is done once, a lot of times these come back positive. They want to maybe have a definite, let's see, they bring them in, they drink this glucose substance, they check their blood glucose level 2 hours later. This is commonly done for gestational diabetes, and you will learn more about that in 113. And again, you could put this in a risk factor for type 2 diabetes. That if you've had gestational diabetes or diabetes when you're pregnant, that increases your risk of getting type 2 later in life. Okay? And I believe an oral glucose tolerance test is above 200. Yes, above 200, then they would consider you to have diabetes. They can also do a urine catch and look at ketones and glucose, and a 24-hour urine test would be looking at kidney function. The thing about a 24-hour urine test, if we do it in the hospital or at home, it doesn't matter. It needs to be kept at cool temperatures, so we keep it on ice or keep it in a refrigerator. In the hospital, we do not keep it in a refrigerator because we do not have a refrigerator that is not have food or other medications in it. Okay? All right. Plan of care. This is we're going to look at what we're collaborating. So here, the plan of care, we're going to collaborate obviously with the physician. We're going to collaborate with a nutritionist and a diabetic educator, and the RN and the NA. Okay? Because the NA is going to be doing a lot of their blood sugars. But what are we going to teach our patient? Okay, so let's look at monitoring. They may have to check it multiple times. They need to know how to rotate fingers. They need to know how to make sure their fingers are clean. They don't always have to use alcohol at home. They can, wash their hands with soap and water. They must know how to check their blood sugar before they leave the hospital. That is key. Now let's look at the school age, preschool. If these are, or even toddlers. They may not be able to check their own blood sugars. The biggest thing for them is maybe have them choose a finger. I mean, these are things that you would read in BAW. So make sure you look at BAW for what is appropriate for a different age of children, okay, because that is going to be tested on. They could choose a finger. School age, may be able to check their blood sugar. They may need to be reminded and have a little bit more supervision. Adolescents should be able to do it on their own, though they may need some reminding if they're anything like my 13-year-old. And adults, same thing. They should be able to check their own. So the collaborative care, we have nutrition, exercise, medication. These are all cornerstones. All three of these things, patients need to know how to check the blood sugar before they leave the hospital, and they need to know how to take their medications and what is hypoglycemia. Nutrition, they'll get the basics. Exercise, they'll get the basics. Because all of this can be done more in depth in outpatient. You have to think about all this information that they're going to get. What is important? Okay? So let's look at nutrition. Nutrition is the cornerstone of care. It is, nutrition, I believe, is addressed on page 1166 and 1167 of your Lewis textbook. the big thing is that you probably read about the plate method, which, you know, is dividing the plate up and you got more vegetables, less lean protein and meat, and less starch, and obviously milk, yogurt, fruits and stuff like that. Everyone has to have protein. 15 to 20% of your protein, it comes from the total calories. You have to have fats. However, you know, we talk about good fats and bad fats. Good fats would be, you know, avocados, olive oil, that type of thing. Bad fats would be butter, vegetable oil, that type of stuff. Or, you know, things that we eat in cookies. But the whole idea is that we do want them to reduce the amount of fats they intake, because in the long run, for everyone, helps reduce our cardiovascular disease, and we know diabetics have a huge risk of cardiovascular disease just based on their diagnosis. Again, it's collaborative, so you may have to collaborate with the nutritionist. Now let's talk about carbohydrates, because carbohydrates are a big part of the diet. You should have about 130 grams of carbohydrates per day. Carbohydrates are made up of fiber, starch, and sugars. But one of the biggest things, the way that people are managing their diet, is what they call by carbohydrate counting. So we count it, and it's a ratio of carbohydrates to insulin. So the doctor orders that. So the most common is 15 CHO, which is short for carbohydrates, to 1 unit of insulin. That's the most common, but you want to always check your orders, okay? So we look at carbohydrates. You have good and bad carbohydrates. We all know that. Good carbohydrates are those that are healthy and are complex. So they technically have more fiber in them. So we're talking about fruits, vegetables, beans, whole grains like quinoa and oats and things like that. Whole wheat pasta, whole wheat breads. Those type of things are complex carbohydrates. Simple carbohydrates are those sugary things like cookies and cakes and ice cream and regular soda and fruit juices and candies and white rice and white bread, all those yummy things. Okay, those are simple carbohydrates. Not so good, but we do need them. And we're going to talk about simple carbohydrates when we talk about hypoglycemia. So, we need to teach patients about carbohydrate counting. There is lists out there. You can Google carbohydrates and they'll say, you know, 1 cup of beans is 15 grams of carbohydrates. 1 slice of bread is 15 grams of carbohydrates. 1 cup of skim milk is about 15 grams of carbohydrates. Okay, so they give you, everything is usually in about 15 grams or 30. And then the patient just adds up. They look at their meal and they add up about how much. And over time, they get really good at this. They can just look at a meal and pop it right out. All right. But we also had to teach them how to read a food label. There's a lot of people who don't know how to read a food label. So I put 2 here on the screen for you to look at. The first one, well, we're going to look at both of them. But the first one I want you to look at, what is important about a food label when I'm counting carbohydrates. First thing is the serving size. That is towards the top. It says serving size, 1 slice. We have calories and fats and things like that. All of those are important. And obviously sodium is important, especially if I have somebody who has congestive heart failure or heart disease or hypertension. But I'm just talking here about carbohydrate counting. So we want to look at the total carbohydrate, which is 11 grams. Now, some endocrinologists are also looking at dietary fiber, and they minus that from the total carbohydrates, but we are not going to do that. That is way more specific, and not everybody does that. But when we count carbohydrates, everyone looks at total carbohydrates. So on that first one, the total carbohydrates is 11 grams. Okay, you see that there? So now let's say that the physician, his ratio or her ratio for carbohydrates to insulin was for every 15 grams of carbohydrate, we're going to give 1 unit of insulin. So it's like a 15 to 1 ratio. So we have 11 grams of carbohydrate. Get your calculator out. We're going to take 11 and divide it by 15. The calculator comes out and it says 0.73333. Now remember, when you're calculating insulin, you only go out to the 10th. So I'm going to say I have 0.7. So I'm going to give how much units of insulin? Because now it's times 1. Times 1 is still 0.7. We round insulin always up to the nearest whole unit. So I'm going to give 1 unit. Okay? So let's look at nutrition slide number 2. Serving size is 1 cup. How many total carbohydrates is this patient getting? 22.2. So put 22.2 divided by 15 comes out on your calculator. It says 1.48. Remember, we only take it out to the 10th, so it's 1.4. So I'm going to round it out to the nearest whole unit. 1.4 is 1 unit. I'm going to give 1 unit of insulin. So let's change this up. Let's say the patient says, well, I'm going to eat 2 cups of this. I love macaroni and cheese. I don't know what this label's for, but let's say it's macaroni and cheese. I want 2 cups of macaroni and cheese. Okay, so I would take 2 cups, 2 times 22.2 is 44.4. So they're going to have a total of 44.4 of carbohydrates. I'm still on the 15 to 1, so I'm going to divide it by 15 equals, the calculator says 2.96. Okay, but remember I only take it out to the 10th, so it's 2.9. So how many units would I give this? I would give them 3. Always make sure you do this calculation, because remember when we calculated it for 1 serving, it was 1 unit. If I say, oh, you're going to have 2, I would just give you 2. I would have underdosed them, and they would have some problems with hyperglycemia a little bit later in the day. So always make sure you do it. Don't take any shortcuts. So I would give them 3 units. So we're going to practice this more in class, okay? Because you're going to have some scenarios, and you're going to have different orders. You might have a different ratio to carbohydrate, ratio from carbohydrates to insulin. But that is nutrition in a nutshell. All right, exercise. Exercise, according to the American Diabetic Association, needs to be regular and consistent, meaning that you don't have to be out there running 5 miles, every Saturday. What they want is, they recommend 30-minute walk 5 times a week. So 5 days a week, okay? They don't say you have to be doing all this crazy stuff. The benefits of exercise are huge. I mean, this is for us too, but it also works for a diabetic. It lowers the blood glucose levels, increases energy, decreases stress. It has a lot of weight loss benefits, but it also helps you maintain weight management, improve your heart healthy, lowers your blood pressure. For a diabetic, it's better use of insulin in your body, increases strength, endurance, and flexibility. So there's a lot of good benefits both for diabetics and non-diabetics. The biggest thing about exercise is that if there's a mismatch between insulin and glucose that is available while I'm exercising, they have a risk of having hypoglycemia, meaning that I have a low blood sugar, less than 70 at some point in time. So there's things that we're going to teach them. We're going to teach them to avoid hypoglycemia while they exercise. So always check their blood sugar prior to exercise. We want it to be as close to normal as possible. Exercise 1 hour after a meal. Or if it's not, if it's at an odd time and you haven't eaten, then you should take a 10 to 15 gram carbohydrate snack. So something that has some complex carbohydrates that's a slow release and not something that's simple that's going to spike up and then fall back down. Okay? So, crackers, things like that, bread, sometimes you'll see them just having a snack, it could be a protein bar or something of that sort. If this exercise is going to be strenuous, such as, running long distances or a long hike or swimming, then we have them obviously do the top 2, check the blood sugar, take a snack, but also bring a snack with you in 30 minutes to 1 hour into your exercise. Stop, recheck your blood sugar, maybe retake a snack, okay? So that's important. We would also encourage them to carry a glucagon pen. A glucagon pen is used for an emergency if they're having a hyperglycemic reaction. So it could be used if the patient becomes unconscious because of hypoglycemia. And or we want them to carry some type of candy or a simple carbohydrate, a simple sugar that if they do feel hypoglycemic while they're exercising, that they can, you know, chew on some candy or some glucose tablets. Now, one big thing that we're going to teach them to avoid, and the reason we have them check their blood sugar, is that if their blood sugar is above 250 and they're going to do a vigorous activity, that they should be avoided if their blood sugar is greater than 250, okay? Because what happens is my blood sugar is already high, I'm going to exercise, I'm going to do this vigorous activity, that the body can see this activity as a stressful event. It's going to release counter-regulatory hormones, therefore increasing their blood sugar. So if I'm 250 and I do some rigorous or vigorous activity, it's going to increase their blood sugars even more, maybe causing them to have some kind of a metabolic acidosis issue. Okay, so we would encourage them to, you know, want to get their blood sugars back down and then do the activity. All right, medications. This, you need to get your textbook out. I am just going to review and point out key things. So let's look at oral medications. This is on page 1163 and 1164. I'm going to look at the table and just read off a few things. All right. One thing I want you to fix in your hard copy of your textbook is where it says biguanide, metformin is the key medication. Under the mechanism of action, it says increase rate. It is supposed to be decrease the rate. The company has already fixed the online version. So if you're using the online book, you're good. If you're using a hardcover book or hard copy book, you need to change that to decrease. Okay? So metformin decreases the rate of hepatic glucose production, augments glucose uptake by tissues, especially in the muscles. So basically what it's saying there is that these medications help your body use insulin better and prevent your liver from releasing glucose. The side effects of metformin is a lot of GI issues. Okay, so it can bloating or gas, diarrhea, but they also can have some liver issues like a lactic acidosis or other liver failure. One big thing about metformin, safety-wise, is that if they're going to have any kind of test, like a CAT scan or PET scan or any kind of heart catheterization where they're going to use a contrast media, that metformin must be held 1 to 2 days or 24 to 48 hours before and 40 hours after. And the reason that is because they both can cause you to have kidney issues. And if I do this, if I give metformin and do that, I could put them into acute renal failure. Now, there are times when, you know, you have to have a heart cardiac catheter because it's an emergency. You know, you have to look at the risks and advantages. All right, sulfonylureas are next. You have glipizide and glyburide. These stimulate the release of insulin from the pancreatic islets. They decrease glycogenolysis and glycogenesis, which is the liver, enhance cellular sensitivity to insulin. Basically, they the biggest job that sulfonylureas do is release insulin from your pancreas. So big side effect from that is hypoglycemia. You want to take these 30 minutes prior to a meal because it takes them about 30 minutes to start working. So they may take them once or twice a day. The next one on your list is meglitinides. You have natglinide and repeglinide. They stimulate rapid and short-lived release of insulin from the pancreas, so very similar to sulfonylureas. However, they're much more rapid, so it's very similar to like rapid-acting insulin. You have to take them with the meal or 15 minutes prior to the meal. Again, side effect is hypoglycemia. You have the alpha glucosidase inhibitors, which is acrobose or miglitol, delay absorption of glucose from the GI tract. So these are taken with every main meal. So they stop you from absorbing the glucose, so much of glucose. Okay, so it kind of helps control glucose. These cause a lot of GI effects because it works within the GI. So they have gas, abdominal pain, diarrhea. All right, let's see. The next one on your list is the thiazolidinedionase, or TZD for short. You have your pioglitazones and your rosiglizones. They increase glucose uptake in the muscle. They decrease glucose production. So they work on the muscle, they work for peripheral resistance, and they work on the liver. So you have to think about, well, what are the side effects if it works on the peripheral? They have weight gain because of all the edema. Okay, this is what they can get. And they can also have liver issues. But you can look at these two different drugs. They both have some cardiovascular. So you do have to be careful about watching for any kind of cardiovascular risk factors on those patients. I'm trying to think, is there anything specific you need to know to do? No. So the only ones here that cause hypoglycemia is your sulfonylureas and your glitinides. The rest of them are usually something different. Diarrhea, GI, that type of thing. The next is the dipeptide peptidase 4, or DPP4, sitagliptin, or Januvia, which is frequently seen on TV. They enhance the activities in incretin, stimulates release of insulin from the pancreas, decreases hepatic glucose production. Basically, what they're saying is they enhance your body's ability to lower blood glucose sugar. So it just enhances the body. There's side effects, pancreatitis, allergic reactions, that type of thing. We're not, you can cross out the dopamine agonist. We're not going to talk about that. Combinations, you do not have to sit here and remember combinations. You know all of these drugs if you know biguanide, sulfonylureas, glitinides, alpha-glucosidase, and the TZDs. You know them all. They're just combos. The next one is the non-insulin injectable agent. So these are injections, but they're not insulin. This is the glucagon-like peptide 1, or the most common ones that we're seeing used out there is the exendide and the liraglutide. Okay, they stimulate release of insulin, decrease glucagon secretion, gastric emptying, basically slows down how fast food leaves the stomach, so then it slows down the absorption, so you're not getting all this glucose all at once. I'm trying to think what else we need to know about that. Nausea, vomiting, hypoglycemia, diarrhea, constipation. So this non-insulin injectable, none of these on this table a type 1 can get. Okay, I want to make sure you understand that. Insulin. So let's look at insulin. The insulin starts on page 1158 and goes to like 1163, right before we talk about orals, or the book talks about orals. I'm not going through all of this. We're going to go over main things. Main things. Big thing that you need to know is the peak of your medications, because the peak times are important, because that's when the patient has the most insulin available and that they're at a higher risk for hypoglycemia, especially if they don't have the glucose on board. I'm going to fix a couple peak times just to be consistent with ATI, but also to be consistent that it's not so hard to remember, okay? So let's look at, I think it's page 1159. There's two tables there. You have rapid-acting insulin. This is Lispro and Aspart. Their peak time is, go ahead and change it there, to 60 to 90 minutes. Because that incorporates both of those, and it's a little easier to remember. So the peak time is 60 to 90 minutes. The thing about Lispro and Aspart is that they are the most common drugs seen in an insulin pump. Okay, so a lot of patients, especially younger patients, teens, children, college students, young adults, are using an insulin pump. It's very convenient. It gives them a basal rate, meaning constantly gives them a little bit of insulin throughout the day, just like our pancreas is doing, and then they can count their carbohydrates, program in how much insulin they need to cover their carbohydrates. So they don't have to give themselves all these injections all day, every day. The next one is short acting. This is regular. Your peak time is about 2 to 5 hours. The thing about regular insulin, or the short acting, is the only insulin approved to be given IV. Okay. Next, you have intermediate, which is MPH. That's your cloudy insulin. So when you're mixing and you're looking at cloudy, this is what we're looking at. All right, MPH insulin peak is about 4 to 12 hours. And then you have your long-acting, which is Glargine and Detromere. Their peaks, there is no peak, okay? The thing about long-acting insulin is it cannot be mixed with any other insulin. And the reason that is because in order for it to maintain its long-acting ability, it has to be given alone, because when it gets into the subcutaneous tissue, it almost becomes, I want to say crystallized, but it becomes like little small crystals that slowly dissolve over the next 24 hours. That's how you get the basal. When you mix it with another insulin, you take it away. It's almost like taking an extended release pill and crushing it and taking it. You get the dose all at once. So long-acting insulin, it cannot be mixed with any other insulin. Okay? So now let's look at insulin. Let's look at the drug therapy, the insulin regimen. The goal is to mimic the pancreas as best as possible. So what they're saying is that an insulin pump is best, but if you can't afford an insulin pump or that is not within your lifestyle, then you need to do multiple injections or multiple doses. So if you look at the very bottom, basal bolus, this closely mimics these two regimens closely mimic what the pancreas does. So either I take a long-acting, which is my basal, and then before all my breakfast, lunch, and dinner, I take a rapid or short-acting insulin. So I'm going to take multiple injections. Or you can use MPH, but you do have to take that twice a day. Doesn't quite get you the best basal, but MPH is a lot cheaper than Glargine, okay? It's just because it's older and it's been around longer. But they're still going to take multiple injections. That best mimics what the normal pancreas is doing right now. All right, anything about insulin in this book, about mixing insulins, about rotating sites, about complications of insulin injections, about insulin, that type of stuff, you need to read on your own. That is something that you've learned in 111. Insulin pumps you can read on your own. We're going to do some highlights about that maybe a little bit later. Insulin pens are most commonly, can be used a lot, especially in the older population, and especially if you have visually impaired patients, because they can kind of dial in the insulin and give it to themselves. And like I said, insulin pump is going to give you a bolus and a basal. All right, treatment of, let's look at complications. So we have treatment of diabetes, meaning I'm taking medications that can cause these problems. Or we're talking about complications from the disease itself. So the first one is hypoglycemia. Hypoglycemia is low blood sugar. It's less than 70. Or it can be because their high blood glucose level falls so quickly that they become symptomatic. So with hypoglycemia, there is a mismatch between insulin and the available carbohydrates or glucose in the blood. So I become hypoglycemic. Manifestations, people can be non-symptomatic or they can be symptomatic. And usually they revolve around some kind of mental, because remember, the brain doesn't store anything. So it relies on a constant flow of glucose so that it can maintain function. So a lot of your signs and symptoms are related to the brain or the central peripheral nervous system. So anxiety, irritability, confusion, they can be lightheaded or dizzy. They can have hunger, rapid heartbeat, shaky, sweaty, hungry. I don't know if I said that. Hungry, because, you know, obviously the body, the cells are saying, hey, we need glucose, so let's eat some more. So that is some of the manifestations that a patient may have. The treatment is what they call the rule of 15, meaning that I check your blood sugar. If you're symptomatic, non-symptomatic, it doesn't matter. If your blood sugar is low, less than 70, we're going to give you 15 grams of carbohydrates. Okay, there's 115 we just talked about. Well, what kind of carbohydrates are we going to give? We are going to give simple carbohydrates. So in the hospital, we're going to give a simple carbohydrate that's available to us is usually juice, regular soda, or milk. We'll give skim milk because we don't want to give them all these extra fats, okay? So skim or 1% milk, something like that. Those are what's available to us. So, rule of 15, right? I'm going to give them 15 grams of carbohydrate. So, that's 4 ounces of juice, 1 cup of milk, or 4 ounces of soda. So, 4 ounces of juice or soda, or 1 cup or 8 ounces of milk is what is available. I'm going to give them this. That doesn't mean I'm going to add sugar and all this other crazy stuff to it. 15. Give them 15 grams of carbohydrates. Wait 15 minutes. Recheck. If blood sugar is above normal, I mean, we're in like 72, what they suggest is that you follow it up with a, something that has maybe a simple sugar and a simple carbohydrate, a complex carbohydrate, and a protein. So maybe I give them another juice and give them peanut butter and crackers or a turkey sandwich or whatever I've got available that I can give them that meets those requirements. Well, let's say in that 15 minutes I recheck and their blood sugar now is only 65. Repeat your 15 grams of carbohydrate, recheck in 15 minutes. It's the rule of 15. Okay, so now let's look at, well, what's different from a preschooler? Well, they like juice, so I'll give them a juice box. Most of your juice box out there are about 4 or 6 ounces, so that's plenty. Maybe they like some candy. That's fine. Okay, but hard candies we try to avoid because most people suck on hard candies. So what does little kids like? They like sweet tarts and gummies and, different things like that. Candy bars, Kisses, those things. Give them some of that. That will help. A school ager likes that too. Okay? So let them be actively involved in choosing their snacks because a lot of times they're very excited. My brother had hypoglycemia when he first became a diabetic. He was so excited he could have regular soda. That was his treat. So let them be involved. Okay, same thing with adults and adolescents. So the treatment doesn't really change a whole lot. It's just how the involvement of the person might be more into it. Now, what happens if somebody is hypoglycemic and we don't know what their blood sugar is? Well, it's kind of like that saying, if it, looks like a duck, sounds like a duck, it must be a duck. So if the patient is if they're diabetic and they're having all these signs and symptoms, I don't have a blood sugar, treat it. It's better to treat it than not to treat it because more people die from hypoglycemia than hyperglycemia. They die a little bit faster, okay? So let's say in the classroom or on the street or in the hospital cafeteria or whatever, you find somebody who's hypoglycemic. Well, I'm going to treat them the same way. I'm going to give them 15 grams of carbohydrate. What if they're unconscious? Hopefully they have their glucagon pen. Glucagon is also in a pen, like an epinephrine pen. You give it into the thigh, goes into the muscle because it gets absorbed faster. It then has to be converted into glucose and voila, they're back awake. Okay? Well, what if they don't have their glucagon pen? Dang, that person, I don't have that pen. Well, put them on their side, a rescue position, and give them something that can be absorbed into the mucous membranes of the mouth. So it could be a frosting, it could be a glucose tablets that can dissolve, and you can chew glucose tablets too. So a lot of these things that we're giving, we could put there. And then obviously we would call for help. Okay, call 911. Maybe they've got some glucose that they can give them or a glucagon pen. Well, what if your patient is in the hospital and you're using the hypoglycemic protocol and they're unconscious, blood sugar is 45, I can't give them anything orally. Well, they have an IV. Okay, or if they don't have an IV, I'm going to give them glucagon because they're in the hospital. I have access to these things. If they have an IV, I'm going to give them glucose IV. Okay, and it's usually pretty strong. It's usually D50. Okay, and we're not going to go over. Every hospital has a different protocol, but just know that you're going to give D50 IV. And then once they're awake, we're going to follow it up with a snack that has a simple carbohydrate, a complex carbohydrate, and a protein. Okay? So the rules of 15. All right. I did that. Go back. Okay. The dawn phenomena. Again, it is a complication from our treatment, things that we're doing, either diet and insulin. If you look on page 1163, it goes into both the Somogyi effect and the Dom phenomena. So let's just look at it. Both of these are hyperglycemic events early in the morning. So usually we find this out, like they're, let's say most of the day their blood sugar is, close to normal. It's like 130, 135 all day. But every morning at 7 o'clock, it's above 300, or it's 250, or it's really high. Well, then what we start looking at is what's happening during the hours of sleep. So the only way to be able to distinguish it if it's Dom phenomena or Somogyi effect is that we're going to check the patient's blood sugar at 3 o'clock in the morning, 0300. So people who are newly diagnosed diabetics, or if we're changing their medicines a lot, we're going to tell them to get up at 3 o'clock and check their blood sugar. Or we're going to be checking their blood sugar at 3 o'clock in the morning in the hospital. Okay? So what's happening? Go in there and check their blood sugar at 3 o'clock. Let's just give a scenario. At 10 o'clock that night, the blood sugar was 140. Okay? At 3 o'clock, I go in there, the blood sugar's 210. At 7 o'clock, it's 305. That is called the dawn phenomena. Think about what happens in the dawn hours. The sun starts rising. The dawn phenomena, blood sugar starts rising. Okay? The Somogyi effect, let's lose the same numbers, okay? At 10 o'clock at night, or the hour of sleep, it's 140. At 3 o'clock we wake them up, their blood sugar is 65 or 50 or 45. It's hypoglycemic. Again, at 7, it's 305. That's Somogyi. What Somogyi is that the patient is having a hypoglycemic event somewhere between 2 and 4 in the morning, that the body has a rebound effect to. Okay, so the body senses you're hypoglycemic. It sends out counter-regulatory hormones to fix the problem. However, it spikes you up. So if we only look at the HS in the morning blood sugars and don't find out what the problem is, we can't really fix it. Okay, so the Dom phenomena usually has to do with, they might have to change up their medicines a little bit to have a better coverage while they're sleeping. Where the Somogyi effect, usually what they're finding out is that they're not getting their bedtime snack. And the bedtime snack usually consists of a simple, complex carbohydrate and a protein. So a lot of times they'll get a turkey sandwich with milk or juice. Okay? And that helps cover them during the sleep. So really, all three of these is a mismatch between insulin and glucose availability. Okay, I hope that makes sense. All right. Diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome, DKA HHS. Type 1s can only get DKA, whereas type 2 can get DKA, but more commonly get HHS. I hope that makes sense. All right, so let's talk about DKA. DKA, remember we kind of talked about that when we talked about polyphagia and weight loss. When a type 1 diabetic doesn't have any insulin, there's no glucose getting into the cell. So the cell is starving. It starts eating its fat. The fat cells produce ketones or acetone. So we have ketoacidosis. Okay, so now I have a metabolic acidosis problem with ketones. We call that diabetic ketoacidosis. Things that we see, their blood sugars could be anywhere between 250 and higher. The process of DKA can start at 250. Now, are they all have all these other crazy symptoms? Maybe not. Okay, but I have seen people who are 250 and have all these symptoms. I've seen people at 400 and have bad symptoms. Or my brother, for instance, his blood sugar was, I believe it was like somewhere in the 500s, and he was already in a diabetic coma. Okay, so DKA, blood sugar can be as low as 250 or higher. The pH is low, less than 7.35. That makes you acid. We then look at the bicarb, or the HCO3. It is low, less than 15. That makes it metabolic issue. They also have ketones and glucose in their urine. signs, physical signs and symptoms, they may be already in a coma. They may be extremely drowsy. They may have Kussmaul's respirations, which is a rapid, deep breathing, because the body's trying to compensate for that metabolic acidosis state, and it's trying to breathe off those ketones, trying to fix the problem. So it's compensating. They can also have a fruity breath. Okay, so it smells like fruitcake or whatever, donuts. I don't know. People have different descriptions. Basically, you're smelling ketones on their breath. Hyperosmolar hyperglycemic syndrome, type 1s do not get, because what's the difference between these two is that HHS is able to produce enough insulin to prevent DKA. So I have enough to prevent the cells from cannibalizing themselves, okay? But I don't have enough insulin out there to prevent a severe hyperglycemic event. Their blood sugars are usually greater than 600. It doesn't prevent a severe osmotic diuresis. They have a lot more dehydration than DKA. So their extracellular fluid is extremely depleted. So there's some figures in your book that you can look at, and I'm sure there's some videos out there. The treatment for both of these are the same. We are going to give fluids. So that's a priority because we're looking at the vascular system. We want to beef that vascular system up. They're going to give them an isotonic, such as normal saline or half normal saline. Most likely would be a bolus, meaning I give a large amount in a short period of time. HHS may get more because they have more dehydration. We are going to give IV insulin. So it's going to be a drip on a pump. We have to do lots of calculations. What kind of insulin is going to be in there? Regular. Remember we talked about regular insulin is the only one that's approved to give an IV. So recall from fluid and electrolyte lecture earlier in this semester, when you give regular insulin IV, it is also used for somebody who has hyperglycemia. So we have to watch somebody's potassium levels if they're getting IV insulin, because they may drop, because insulin also pushes the potassium into the cell. So we may have to hang or add potassium to the regular IV fluids, or you may have to hang mini bags. And remember, you can only infuse 10 milliequivalents of potassium per hour, and that has to do with cardiac issues. Okay, so we're giving fluids, we're giving IV insulin, we're going to be checking that blood sugar every 30 minutes to an hour. Though that's the hallmark right there, and possibly giving potassium, okay? When their blood sugar reaches 250, as the nurse, I want to make sure that this blood sugar does not drop so fast that they have cerebral edema. Because remember that osmotic issues with glucose, that if their blood sugars drop so fast, they can get cerebral edema. So when it hits 250, we want to see some dextrose added to the IV. It can be D5 or it can be D10. So now their IV fluids may change to D5 normal saline, or D5.5, or D10 normal saline, or D10.5 normal saline. Okay, we're just adding dextrose to whatever was hanging. And that just helps us to gradually lower their blood sugar, because they're still going to have insulin. Either it's going to be still IV or they've changed it over to sub-Q. So they've got to have insulin. Okay. Now, what caused my patient to have this problem? The two biggest things is not taking their medication, so not taking their insulin or their meds, or they're sick. So let's go over sick day rules, and I'm going to just read you what ATI and another source has in sick day rules, because Lewis really doesn't address sick day rules, but Ball does. All right, sick day rules. When they're sick, they're encouraged to check their blood sugar more frequently, at least every 4 hours. It could be more than that. It just depends upon the person. They are to continue taking medications or insulin even if you are vomiting and not eating. Okay? Drink at least a cup of water or sugar-free fluids like broth, tea, coffee every hour, and that's for you or I. That's to maintain hydration. Okay? Obviously, we want them to relax, rest and relax. If they're unable to eat solid foods, try drinking fruit juice or eating crackers, eating soup, broth, Jell-O, or even popsicles. These foods do not have to be sugar-free. okay, because we're replacing meals with something else. If you are unable to keep food down, drink something with sugar in it. Obviously, we talked about that, but something like ginger ale, Sprite, 7-Up, you know, things that I drink when I'm sick. A lot of times when they're sick, they want them to test their urine for ketones, so they want them to do that. They are to call or seek medical attention if they cannot think clearly, they have trouble breathing, their blood sugar is greater than 240 for 24 hours. They have large amounts of ketones in their urine. They have vomited more than once, or they have diarrhea for more than 6 hours, or they feel sleepier than normal, because all of these things can lead to DKA or HHS. Okay, so we have sick day rules that they need to kind of go by. Okay, we went over that slide already. All right, let's look at chronic complications. These are long-term. We have macro and micro. So we're looking at vascular issues, and the vascular issues also affect our nerves, because if I don't have good circulation to some of these small basement nerves, then obviously they're not going to function correctly. Okay, so macrovascular, these are our large and medium vessels. These are a lot of coronary artery disease, cardiomyopathy, abnormal blood clotting, and obviously CVA or strokes. Microvascular are our small little vessels. Okay, this is very specific to diabetes. However, there are some other illnesses out there that can have these problems, but these are the little capillaries and arterioles that are affected. So retinopathy is the retina, so we have blindness. Neuropathy are your nerves. So you can have, gastroparesis, which is, the nerves in the stomach are affected, so you're not digesting properly. You can have erectile dysfunction because of vaginal dryness, decreased libido, erectile dysfunction, that type of thing. Let's see, neuropathy. Oh, peripheral neuropathy. That's of the toes, mostly the toes and feet. But neuropathy is, a group of things. Nephropathy, you're looking at kidneys. The number one reason people are sitting in dialysis chairs is because of chronic renal failure due to diabetes. And then you have a combination of both the large vessels and the small vessels, and this is peripheral vascular disease. Usually you hear people call it, in diabetics, is they have a diabetic foot. They come in with an ulcer on their foot, or, the foot is starting to turn blue, black, gray, whatever, because they don't have good circulation. They can't feel anything down there because of peripheral neuropathy. All of these complications, you're not going to totally eradicate the risks, but you can decrease the risk. And the biggest thing is that we teach them to keep their blood glucose as close to normal as possible. So, again, the goal is to keep somebody who's a diabetic to less than 140. Close, we love for them to keep as close to, 105, 120. In that range, is the best, but obviously that is not always optimal. Foot care, I'm going to, again, read you something about foot care, because that is very important, because we see more problems with foot care problems. Obviously, we want to keep their blood sugar as close to normal, but foot care tips: do not smoke. Smoking damages the blood supply to your feet, just like diabetes. So if you're doing both, it's a double whammy. Never go barefoot. Never wear, flip-flops or open-toed shoes, or even they talk about pointed shoes or plastic shoes, because they do rub your feet. If you have new shoes, wear them in, or just wear them for short periods of time until they're much more relaxed, so you don't have blisters and, calluses that develop. Check your feet every day. You want to check the top, bottom, sides, in between your toes. Watch out for any cracks or open areas. Wash your feet with mild soap and warm water. Do not soak your feet. That causes an increased dryness, and when I have increased dryness, I have a risk for cracks. Always test the water with another part of your body. If you're getting into the tub, Do not use your foot. If you have a diabetic foot, you do not use your foot to test the water because you cannot feel how hot it is, and you will burn yourself. Apply lotion or creams to your feet before putting on your socks and shoes and before going to bed. We want to keep their feet nice and soft and supple because if it's dry, then you're going to get cracks and problems. However, remember, when you are in a nursing assistant program, you do not apply cream in between the toes because that just breeds a area for infection. So don't do that. Not between the toes. Everywhere else. Talked about flip-flops. Do not cross your legs at the ankle and cross your legs at the ankle, not at your knee. If your feet are cold at night, wear socks. Do not use a hot water bottle or heating pad on your feet because you will burn your feet. There are many people who have come in with 2nd and 3rd degree burns because they could not feel that their feet were burning. Okay? Again, you want to maintain blood glucose levels as close to normal. I hope that this little preparation is a good little tool for you to get ready for class. I know it's a little long, but it does give you a good overview, and when we're in class on that first day, that flip class day, we're going to implement a lot of things, and a lot of this stuff is going to be pounded into your head a lot more through case studies and what ifs and what if this happened, and if you're going to send somebody to the OR, what am I going to do, that type of stuff. So I hope it helped you out, and if you have any questions, please write them down. If you wish to go ahead and do the questions, remember I gave you options. You've chosen to listen to the video and look at your book, but if you want to go ahead and then try to answer the questions after you've listened to this, that is great. Okay? But anyways, thank you for your time and